I'm sure many of us in the room saw many similarities there in terms of problems introducing a new thing to an intensive care unit, problems reaching out to cardiac surgeons as well. I'd like to invite Yahya to tell us the next step.
You'll be pleased to know that I'm going to be the last speaker, so I'll try and hurry up. Now that we've gone through the first three objectives of our program, where we've achieved the results of the observational trial, and we've done the intervention, we've done the pilot. We have named the intervention we put all together as early goal-directed sedation. And I want to make a very big disclosure here that I am not related to this gentleman, and that I have not used these catheters except in the ARISE study. And for that reason, I also have, I know this algorithm, but our early goal-directed sedation is not based on this algorithm. We've now identified the modifiable elements of our sedation practice, and we're now going ahead with our fourth and final stage of the program, and that's to test the hypothesis that early goal-directed sedation would influence long-term survival and functional dependence. So just to remind you again, the early goal-directed sedation is about delivering intervention early, within hours of ventilation, maintaining light sedation, minimizing benzodiazepines and drugs that accumulate, targeting light sedation right through, and providing effective analgesia, and hopefully that will also reduce delirium. And there's a lot of studies that have shown in different ways that targeting light sedation is actually associated with improved outcome. And without having to go through each one of those studies, most of you is quite familiar with most of these studies, but there is a couple that I'm particularly wanted to go through with you. This is two studies that I think are very important. One is the ABC trial, which essentially looked at a daily sedation interruption to mandate light sedation, coordinated with a spontaneous breathing trial. And although the ABC trial may not relate to our practice in Australia and New Zealand, but as a concept of providing light sedation and coordinated ventilation weaning, it is actually an important trial. And it did show that it reduced ventilation time, ICU stay. More importantly, it showed that at 1 year, there was a substantial reduction in mortality. You can see that there's about 32% reduction in mortality at 1 year, and that translates to about 14% absolute reduction. The second study about light sedation is a before and after treatment, not a randomized trial. And the reason I put that there, because this would mimic an early intervention trial. Because an early intervention trial, you start from the beginning. That's what this before and after study done by Ivona Skrobik in Canada actually did. They had a bunch of intervention where they targeted light sedation, and they targeted effective analgesia and a lot of other bunch of interventions to look at patients' outcome. And they also showed in that study that at hospital discharge, they produced 6% absolute reduction in mortality. So there are studies there that showed that putting together a bunch of intervention that target light sedation and provide effective analgesia, amongst other things, can actually produce reduced mortality. Why we've used dexmedetomidine as our primary sedative in this trial? Because multiple trials have shown that dexmedetomidine is a drug that enhances cooperative sedation, light sedation. It's hard to make people asleep with it. It reduces ventilation time and also reduces level of coma. So the main RCTs on dexmedetomidine in a systematic review showed that there is a possible benefit when it comes to mortality, but when you add the studies that we saw today from Professor Takala, that actually becomes almost undetectable. So this is the reason why we've chosen to use DIX as part of the early goal-directed sedation, and the pilot that we've done has proven that concept. So the early goal-directed sedation, the main hypothesis is that it would reduce 90-day all-cause mortality in patients who are ventilated for longer than 24 hours. Our primary aim is to look at the 90-day all-cause mortality amongst all comers treated with the early goal-directed sedation. So there's a bunch of secondary outcomes. The most important of those secondary outcomes is institutional dependency at 90 days. So those who are in full-time residential nursing care are going to be looked as their institution independent at 90 days and in 6 months. There's also a bunch of other ICU outcomes like reintubation, tracheostomy, delirium, ICU mortality, and ventilation time. There's also hospital outcomes, but there's also an outcome of cognitive function or dysfunction and health-rated quality of life at 6 months after randomization. So the study is going to look at a multiplicity of hospital and out-of-hospital long-term outcomes that are patient-centered and are important. The design of the study is a process of care, multi-center, randomized by a central website, but it would be unblinded study because it's a randomized, it's a process of care. You're delivering multiple intervention, and if we're going to follow the double dummy blinded what we've done in Europe, we will end up running 6 infusions at the same time, which is quite unsafe. So we are looking at a pragmatic study that will really look at comparing an early goal-directed care against standard care. From the observational trial that we did, we found that our baseline 90-day mortality is about 26%. So we are looking at we took the 2 ABC trial and the Scrobic trial, we took the pooled effect of mortality reduction from those 2 trials, and we're trying to achieve 50% of that mortality reduction in our trial. So our trial is powered to detect 4.5% absolute reduction in mortality at 90% power at a level of 0.05. For that, we need about 4,000 patients, and we expect that those 4,000 patients recruited probably will be in about a 3 years period. There will be an interim analysis done at 2,000 patients. The inclusions, again, is the similar inclusion to what we've done in the observational and also in the pilot. The exclusion is also pretty similar with some minor adjustments. For example, we will exclude only those who have fulminant hepatic failure, not severe liver dysfunction, for example. The study algorithm is also similar to what in the pilot. Patients will be randomized, screened and randomized. Once they're randomized, the clinicians will make sure that they have adequate analgesia, and they will get their pain, agitation, and delirium assessment as first assessment post-randomization. Then they will go into one of the 2 arms. The early goal-directed arm essentially is no benzodiazepines again starts with the same dose of 1 mg per kilo per hour of dexmedetomidine. The dose of propofol that's going to be allowed to be used is only about 0 to 7 mils per hour. So it's a low dose propofol because we don't want people to end up using a lot of propofol and making people deeply sedated. The mandated target RASS in this group is going to be -2 to +1 from the time of randomization. So that's a major difference here. While in the standard care arm, where we expect that the most patients will be getting either midazolam or propofol, as we found in the observational data, there will be a recommendation for light sedation. So light sedation, -2 to +1, would be encouraged at all times, and that will be done by the treating team. And infusions would be managed as per standard practice by the nurses and the doctors at the bedside. If patient becomes agitated, in the early goal-directed arm, after optimizing the level of dexmedetomidine, quetiapine and haloperidol can be added. If after all that they're still agitated, they get midazolam or any benzodiazepine. In the standard arm, you optimize their conventional sedatives, including propofol and benzodiazepines, and then you add quetiapine or haloperidol. If all that fails, you can add open-label dexmedetomidine. So we have submitted a NHMRC major grant for 2012, and we should know the result of that grant in October. We have secured from Hospira, we're very thankful for Hospira for doing that, that the study drug will be delivered to all sites free of charge. And there will be, as with all other CTG in those studies, a competitive per patient payment for those who are going to be recruited. Now the SPICE have a logo. We have an early goal-directed sedation. We are all ready. We want you to come along with us. Thank you very much.